Yes, sir. Start.
So I'll be presenting a case of unusual subretinal fluid following open globe injury. So several causes of subretinal fluid are attributed to trauma. Few case reports describe central serous chorioretinopathy like picture following trauma, but that's very unusual. We present a rare case of open globe injury who presented with CSR like picture while on treatment with oral steroids. The dilemma of considering other differential diagnosis and multimodal imaging will be discussed. So this patient was a 45-year-old neurosurgeon who was my colleague, and he was injured with a racket while playing squash with the anesthetist who was working with him throughout the day. His vision at presentation was PL with inaccurate PR. When I opened the lids, there was a scleral tear which was roughly 10 millimeters long, superior to the limbus. There was iris prolapse and hyphema. So immediately, with the help of the same anesthetist, I planned him for globe repair. So the scleral tear repair was straightforward. He had a superior scleral tear, which was repaired with vical sutures with the AC wash. And then finally, I closed the conjunctiva with fibrin glue. And this was the appearance at the end of the surgery. The patient was doing fine. While on day 3, I had a dilemma. He had increasing hypopion. There was mild increase in pain, few vitreous echoes. So I had a doubt whether to inject or not, but benefit of doubt given to the patient, and he was given intravitreal injections, and he did good after that. So he was a surgeon himself, so he kept on asking me when he cosmetically he found that his globe is restored. So he said that initially, what if we have missed a glass piece inside my eye? So as a precautionary measure, I did a CT on him, and along with that, the radiologist advised to do the CT of the spectacles also, because sometimes the Hounsfield unit could be deceptive and we could not pick up a glass piece. However, I have already done a X-ray at the baseline. Unusual inflammation, I also suspected whether the lens capsule was integrity is disrupted. So the OCT in such situations can be very helpful. The actual dilemma started after 2 weeks when we started developing subretinal fluid. Here you can see in the OCT. So I started thinking of post-trauma CSR because he was already on oral steroids and he was a smoker. I had not done a depressed examination, so I thought it could be a peripheral break or commotio retinae. But theoretically, I also thought of a very, very rare type of sympathetic ophthalmia, which is presenting in this eye. However, the multimodal imaging, when I zoomed into the OCT, I found that the outer retinal layers are dipping into the choroid here, and there was a very small RP aperture, which was leading to this CSR. So CSR due to this was a case of CSR due to RP tear. The sympathetic ophthalmia was ruled out based on the FFA. There was no disc leak or there was no inflammation, and I decided to stop the oral steroids. So this was because of the small RP aperture-like tear, which was picked up on multimodal imaging. There was choroidal hypoperfusion most likely, and which led to collection of this subretinal fluid. However, in this case, the force was just enough to tear the RPE. Larger forces could lead to rupture of Brooks membrane or choroid rupture. So this case highlights rare occurrence of CSR post-trauma with RP tear. Multimodal imaging confirmed the diagnosis in this case, and the dilemma to stop steroids for prophylaxis of sympathetic ophthalmitis also could be taken, the decision could be taken based on this imaging. Now this patient, this neurosurgeon, he is very happy. He is finally, his vision was 612 and he has started operating his patients, and now he has become like our brand ambassador, wherein he always uses protective glasses and educates people about this. Thank you.
So your diagnosis is that it's a separate entity, not associated with trauma.
Yes, sir. But in this case, we could pick up that there was a anatomical damage to the RPE, so it was most likely the fluid exuded from that area, sir.
But the injury was quite anterior.
It was quite anterior. He had some vitreous hemorrhage also, so most likely because of the counter coup mechanism, the posterior pole was had also received the impact.
So the final vision was 612.
Final vision is 612.
Yes.
The final vision is 612 because this area is not in the center of the fovea. It is slightly away. There is slight foveal thinning, but his vision is 612.
The final OCT?
The final OCT, this fluid had subsided, but there was a slight foveal atrophy. The CMT was roughly around 182, sir. But center of the
182.
fovea was fine. That foveal dip was maintained.
Maintained.
But 612 vision is difficult to, no, it's best corrected.
It is best corrected vision.
No, you told 10 mm long scleral tear.
10 mm long scleral tear,
Okay.
but it was not involving the lens or the visual axis, ma'am.
Okay, that
And
scleral tear, adjacent areas, retina, periphery, everything was okay.
periphery, subsequently after a
No
month,
breaks or holes, nothing, no
nothing.
intervention done.
Nothing, ma'am. No intervention.
Vitreous hemorrhage resolved on itself, or you?
No, vitreous hemorrhage resolved on its own.
How many days?
It took almost around 3 weeks.
By 3 weeks, it was clear, and the patient got 612.
The vision was 612. There was some inferior vitreous hemorrhage which took a little longer time, but the vision was 612, and he has started operating now.
Okay.
You spoke about anterior chamber reaction with hypopion. What happened to that later on?
Ma'am, actually, this dilemma was whether it is a lens particle glaucoma, or it is endophthalmitis, or it is the hyphema slowly, which is settling down. So it was actually the hyphema. So another clue we got from this case, that whenever you have a pigmented red colored hypopion kind of thing, which you are thinking in post-op scenario, you should wait and watch for some time if there is no increasing signs of endophthalmitis in this case. So it was actually hyphema in this case.
What message will you give after you manage a case of trauma?
So in this case, one is whenever the
What
media,
you missed in it initially?
initially if I would have done a OCT in the initial setting, then maybe, but that time the media did not permit me because he presented with PL
That is
vision.
not possible at that
Yes,
time.
at that time it was
But
not
I think
possible.
imaging should be done before going for repair.
But X-ray we had done, ma'am. CT we have not done. We, as per our protocol, we always do a X-ray because of medical legal requirements. But in every case,
X-ray
we do
will
not.
highlight only the
Metallic,
metallic
yes.
foreign bodies,
And
not
that
the
was
glass
yes,
particle.
ma'am. That was a night time, and the CT was taking slightly longer time. So immediately, in the kind of setup I work, so the CT was deferred.
Okay. Ideally, we should do imaging,
Yes,
then go for repair.
yes.